Now, this panel's interesting because what we have here is a really broad spectrum of innovation in diagnostics and of application in AI diagnostics. So we've got investors, we've got research collaborations, and we've got data-driven care in kidneys and omics, right, and genetics and stuff like that. So my job is to try and kind of get you all to gel and to get the sort of squeeze the juice out of you. So one of the things, so my first question, and I spoke to Anmol about this earlier, so I'm going to start with him and I'm going to give everyone else a chance to think about this. But in 2 minutes, what I really want you to do is to give me some examples of how AI is improving diagnostics at the moment, and feel free to kind of brag about your own organizations. And then after that, we will talk a bit more about where it's exceeding care. But anyway, Anmol, would you like to go ahead? 2 minutes, remember.
Definitely. So I'm a cardiologist from Canada, Calgary. So BioAro is a precision medicine company, expertise in multi-omics, sequencing analysis in-house, along with the unique platform we have built called Panomic, which is the world's first multi-genomic platform, providing a real-time analysis in less than 5 minutes. Because healthcare matters when delivered on time. If it's not delivered on time, whole genome sequencing report coming back after 3 months or month is useless to me as a cardiologist. I want a same-day report as soon as the patient is in front of me. And how AI is changing diagnostic field. I can give you a few examples how we apply. We have invested into technology at-home biomarker testing from cardiology, troponin, D-dimer, NT-proBNP, and just immediately putting a drop of blood on lateral flow test, opening up your iPhone and doing image analysis that quantifies that from qualitative.
You're looking at the blood?
Literally, you look at the blood drop and it's a lateral flow test. So it becomes a positive and negative. So from there, depending on how thick the lines are, and we convert into grayscale from color pictures. And from there, AI quantifies the level of antibodies in the blood. And in 15 minutes, we have the result. So imagine in the future, people never have to stuck in emergency room. And all this cardiac biomarker could be done in a plane. Or could be in the space station. So one example of how we are investing in, and we are building these technologies advanced. And from a multi-omic side, so what we do is we look at not only genome sequencing, we're looking at the downstream impact of that, from a transcriptomics to proteomics. So we are picking up biomarkers, picking up predispositions and linking them together, either patient with cardiomyopathy or patients with advanced dementia, or having a woman health challenges, and bringing things together. So from a vaginal microbiome, gut microbiomics, and linking with the metabolomic data into what the patient profile is. So this is how healthcare is now changing and shifting. I call it healthcare 3.0. And that is a healthcare 3.0 means that you have omic as a layer, and then you add on blood biomarkers or simple blood testing, add on imaging, ultrasounds, MRI, and environmental data, patients' wearable data. And from there, AI now can help us predict not only when the disease could be happening, perhaps we can intercept the disease before happening.
Anke, you joined a little late. Just want to welcome you to the panel. And did you hear the question?
Yes, I did. Thank you.
Great. I just thought I'd check. I'm going to come to you in a little bit. Madhu, you're next.
Of course. So I'm not going to be as highfalutin as everybody else. I'm just telling you that right up. Madhu Narasimhan, I work at DaVita Kidney Care. So we care for the lives of about 350,000 people across 15 countries. We're headquartered in the US. And when I talk about I'm not going to be highfalutin, is we have a number of treatments we do per day, and we call them lives extended. Just so that what we do dialysis services. So the question you had was, where are we using AI? I will talk through an example, and then you will see how we use AI. The first is we have an AI model that looks at patients who are dialyzing at home. So dialysis, for people who are not familiar with it, 3 times a week, you have to sit 4 hours with the machine while it cleans your blood for you because you can't do it with your kidneys. So we have an AI model that looks at the data for these patients who are doing this at home. And if they are going to stop doing it because it is hard, we know before they know. So that's a predictive model that we've built with using AI. So we use the model and it flagged to one of the physicians. The physicians looked at that information and the data that went with it, contacted the patient and said, I think I see something else. The patient did have another condition that they went and took care of, and you know what? They've been very regular since. The reason I call this as a practical example is I want to talk about three things that we believe. We believe that our physicians and clinicians are super important, and that's who we augment with our AI. We cannot do what they can do. That empathy and that caring has to come from them. The second piece of it is, you said, how do we diagnose before? How do we find it early? We care for our patients holistically, including the omics as well as the social determinants of care. So how do we bring all that to bear in the care of our patient? And the last piece of it, I think I heard earlier this morning, data and interoperability. Today, all of the interoperability that happens is mostly on paper and faxes. How do we make sure that all of the data comes together in a way that supports the patient? So those are the three things we've done, and I just thought a practical example is just easier.
I think practical examples are wonderful, absolutely wonderful. So I would encourage you to do that. Go ahead.
Well, most of my work remains at a system level as an implementation scientist, and I think the conversation that I have with almost everyone, it's mostly doctors, and my conversation is reassuringly, AI is not going to take your job, so calm down, please. Don't be intimidated by AI itself.
Yeah, we're aligned.
But again, at the same time, what any of the implementation scientists actually do is we try and assist tech founders, tech innovators, and developers like Anmol's company itself to say that there's a beautiful product, this is how it's supposed to work, but then there's a mismatch in terms of how it's going to be implemented on the ground. And that mismatch might actually result into a failure of that beautiful product that's out there. Why does this happen? There's numerous reasons. They can be financial, technical, structural, human behavioral. Your patient might just not accept a particular intervention that you might be able to give them, like dialysis at home. They might just not be comfortable. Think about a 95-year-old person who's like, I don't know how this works. I don't want to do this here. So this is where we come in to say that, okay, how are we going to address all the underlying issues? We know that AI is not a new thing. And we also know that AI is not just a bubble that is growing today and it's going to burst tomorrow. It's something that's here to stay. And rightfully, as been mentioned by one of the panelists, it's a 3.0 for healthcare. What we really need to focus on as doctors, as physicians, as tech innovators, as any stakeholder in healthcare is how we can make this transition in a smooth way, but at the same time, try and keep peace.
But so you work in orthopedics, you're in this network of clinicians, right? And so what diagnostics are changing orthopedics?
So in terms of orthopedics, it's the OrthoGlobe institution that I work with particularly, not orthopedics myself,
right?
Say. But with orthopedic care, in terms of what we're doing, mainly is working on rehabilitative care for a lot of the patients that are out there. People who've had knee replacement surgeries, people who've had hip replacement surgeries. A lot of these patients actually also end up having post-operative pain. And not only just the pain, but a lot of the people who end up having the surgery are unaware to say that this is what's going to happen. Why does this happen? There's multiple reasons. You have risk factors that can actually be calculated pre-operatively and give them a realistic picture. This is just one of the examples. Say, you might be having 60% of a higher chance of having chronic pain for at least the next couple of months, depending on your risk factors. And this helps them understand that this isn't going to be an easy journey, but at the same time, what they're facing currently is something that's going to be much more relieved eventually.
Gabriele, sorry to leave you till the last. Oh, we've actually got another panelist there. Gabriele, your thoughts on...
Yeah, sure. So I'm a bit of a probably different person in the room. I'm investor, venture capitalist. So I'm a bit, I guess, to an extent, worried. I haven't heard cost or what does it cost, how much money we can save, right? In the UK and abroad, it's all about AI, exciting, ChatGPT, but so I'm bringing us back
you
to
invest in these technologies.
exactly. So
what
that's
are
where
you
I'm
investing?
that's where I'm getting. So I'm just here to bring us back a little bit to reality, because it costs a lot, and there's a lot of cost efficiencies with AI. And I wouldn't be so sure it won't take our jobs. It will reduce some of the job scope for sure. So I represent XTX Markets. We're actually a market maker. We deploy algorithms into financial markets, do so profitably, and we reinvest the funds. We primarily invest in machine learning technologies, and very often that's in healthcare, because that's where we find structured, quality, multimodal data. So the way we think about it is, let's look at what machine learning can do within healthcare, and how we approach investment is this: which technologies today within software and across Europe and UK can actually sell into NHS, sell into private sector, of course do so in US, and do so profitably. There are people who are using them, buying them, and you can actually show return on investment, right? So with specifically, and we have a kind of quite large healthcare portfolio. One of my favorite ones right now is, and leading really machine learning dynamics in UK, in Cambridge, Curate, but more specifically within detection and diagnostic space, which is today a bit more about, is I really split into two. So first is pre-biopsy, and then next is after biopsy, specifically for instance, if we took only cancer. And so we backed, for example, Lucida Medical, right? That's focused specifically looking at the imaging, diagnostics, and scans in order to avoid the testing. This is my cost efficiency and saving part there. And then, for example, IBEX Analytics, that's right now across UK, Tel Aviv, Israel, as well as US, is looking what happens after biopsy, right? From prostate, breast cancers, and different lines. And this is where you see specifically the cost efficiency, but also kind of NHS and many private and public sector represents this paying for it. So I think it's very important, the question to go back to, okay, exciting potential, but how do we make sure that it makes sense also kind of from capital perspective?
Well, so you've raised an important point, because I'm sitting here kind of saying, well, what can we do with these technologies that we couldn't do before? And one of them is to save money. And then Anke, I would just, could I turn the question to you? I mean, I'm really keen, I suppose, we've heard quite a lot of answers, but you've got more of an academic perspective of sort of like, where with the AI diagnostics, kind of like what's really exciting right now, what's working and why, I guess, is something I'd really like to understand.
Yes, thank you very much for the question and for giving me the chance to actually tell you about University Medicine Essen, which is the largest university hospital that is offering healthcare services in the metropolitan area of Rhine-Ruhr, with more than 10 million inhabitants. So I actually appreciated very much that, Madhu, you just said, well, we have to, start a step beforehand. We have to talk about interoperability first. So the University of Medicine Essen has got its own platform. We do have 2 billion FHIR resources in this platform. So we run entirely on FHIR, and we've got a very large Institute for Artificial Intelligence in Medicine. Therefore, we have developed our own, actually literally dozens of applications that use these interoperable data sets in our data repository in order to make AI work for our patients. So this is, of course, in monomodal things like radiology or pathology or dermatology. But of course, it becomes really interesting if you look at multimodal AI applications. And there we do have this privilege of having curated, annotated data sets, all fully interoperable in our FHIR data repository. So hence we can do things like clinical decision support applications when it comes to therapies or diagnostics, just combining, lab test results with clinical symptoms and pathology or radiology. So that is actually quite exciting, but it does bring me to the point straight away that we're all talking about University of Medicine Essen. So everything on our own patient data, but nothing cross-sector data analytics or nothing from outside.
And so when you say nothing from outside, you're developing all these internally, and that is both a strength but also potentially a weakness, because what you're developing really perhaps is not relevant to other hospitals in your region even.
No, it's using the data sets, So like the way the German health system is actually working, we do have data silos. I suppose that is the same literally everywhere, except for probably Israel with HMOs, So you can't really easily produce longitudinal data sets for precision medicine that actually have interoperable data in them. And so for our own systems, we can use, training data, but we can also apply all these algorithms that we develop. And of course, you can develop them further to a medical product and then sell them, especially when it comes to things like discharge letters, automation, documentation, all these things. But many of them do need interoperable data sets from different sources. And that is something that there is a huge lack of when it comes to, health data as such.
Anmol, you're obviously developing a system kind of external to, you're a small company trying to sort of sell products into these systems. How do you think about kind of like how you position yourself kind of compared, in terms of what you're selling? And the fact that hospitals can develop their own AI systems. How do you kind of think about?
Well, I can give you one example. I was at King's College, London, a couple of days ago. They got interested in one of our technology called BioMind. So that deals with the mild cognitive delay patient population to advanced dementia. And they have a brain institute. And what we offered to them was a multi-omic analysis, because in Calgary, we have a multi-omics lab from a proteomic analysis such as tau protein, beta amyloid, to advanced spinal fluid analysis, and they can cross-validation done through blood. So we have a high throughput lab where you can do whole genome sequencing, transcriptomics, microbiomics in their patient population. We offer them a service which they don't have currently right now. The biggest challenge they're facing is the testings are going to multiple different areas. The data is getting stuck and never getting timely analyzed. So then we offer panomic software technology, which brings everything together real time. You can analyze the whole population UK in one day if you have the FASTQ file or a BCF file. That fast is our technology. And it's 100% accurate. We did a College of American Pathology assessment, proficiency testing. It came back 100% match. So name a one test in medicine and cardiology, at least I don't know there is a 100% match, being not a single false positive negative called out. And then we offered the King's College, bringing in advanced AI technology, which we have BioMind mobile application, looking at people who got identified at risk for potential dementia, and also how we can keep them entertained, predict them when they're going to get worse by using games, which has been validated in neuroplasticity. So in BioMind technology, not only getting used here, want to use in UK at King's College, Japanese want to use the same technology right now. And in fact, this is the only company from Canada invited to present in Osaka Expo this week, as I'm in the UK. So this is how positioning is. So what we offer to universities and academic centers, to private labs, we are the future company. We are going to help you, power you. You are struggling with a large amount of data. You don't know how to analyze it. Your research teams are struggling, and it's taking a long time to finish the research projects, and the clinical care is suffering. So we are here to bring things together. Now, coming back to interoperability, we build world's next generation health record system called BioELR. It's electronic longitudinal record system. All this data, the wearable data that is stays with the patient, now comes to the doctors. Our AI monitors it, and now it provide guidance to the doctors like an assistant, like a junior resident, and the patient's information getting secured and shared in a secure manner into various platforms. So we not only help them from a lab side, analysis side, but also data how can be secured using advanced technologies. And one last example I share is a facial recognition. We developed a technology from a facial scan. You can pick up blood pressure and heart rate. So King's College and other areas, they want to use the technology. So that allows them to predict who's getting anxious.
Can I respond to that actually?
Parth actually kind of tweaked me first, and please go ahead, Gabrielle. Yeah.
Just very quickly, either that, which is a long approach to the market and selling, we find, or we've had, for instance, case where simply this year in March, we had AI diagnosed cancer and saved 5 patients versus what radiologists couldn't do. That sells very fast as well, just saving specifically lives, which today AI is able to do.
But
and it's been covered in news because service proving that, we can do better, we have better data. They have the data and service layer still helps, but it just sales cycle tends to be a year to 2 years usually.
And maybe we are very fast in sales cycle. We deploy direct to consumer. BioMind will be in UK in January, and it will be subscription-based model. Anyone 40 plus year age, minimal cognitive delay can sign up. And all the omic testing will be done and point of care from your home, picked up samples. So this will advance how we are. So we are going to help the healthcare systems not only upgrade their infrastructure, the knowledge we have to bring it as a knowledge translation, and at the same time, direct to consumer has to be tackled. And there's a huge gap that exists in the healthcare system. That's where we are. So BioMind is one example. BioGut is the same way, target gut health, and looking at a biosports company, looking at sports genomic and excelling on the field.
Fascinating conversation. You're next. Go on, Parth.
Just driving back to your main point question to say what is restricting hospitals from coming up with their own solutions rather than depending.
It was a very badly worded question, so thank you for putting it so well.
Just to put it out, hospitals are a very dynamic institution. They have a very finite amount of financial resources as well as human capabilities, and they really need to prioritize where they're going to utilize the pot of resources that they have. For example, within the NHS itself, we have a very constrained budget. We have technology that is incoming that's beautifully new, but then the technology that's pre-existing, like sometimes if you walk into certain hospital trusts, there are computers that are so outdated they take up to 10 minutes to just be powered on. So if I was a chief executive officer, would I want to bring in new computers? Would I want to put in that money to try and create an entire new set of technology? I know some trusts have gone as far as drone deliveries and all these novel institutions, but they've also faced severe backlash in terms of, if I'm working there, but I'm not able to provide basic care, what am I going to do? So in such instances, sometimes it's very important that we outsource and try and protect the amount of resources that we have to divert it to something more important.
So I have a different perspective, and I'm going to say, so our belief is it's a false choice to say that we're not going to give excellent clinical care and we're not going to handle costs. This is why I say that. What we choose to build is going to be specific to kidney care, the stuff that only we can build because we have the data. Remember, we have longitudinal data over 30 years of our patients who come in 3 times a week, so quality data. However, it's our patients' data, not our data. So anything we build with that's specific for them, we will build. Everything else, you buy. Now the question is, where are we going to get the cost saves? I think we had said earlier, there is a tremendous amount of savings in the back office procedures, the administration of the healthcare. Those things can go faster. They are easy to get done. They will provide the cost savings so that we don't have to reduce the level of care, because that isn't where we would go.
But Madhu, if you're working on patient data and you're in a public health system and you've developed this whizzy model that serves your 300,000 patients, I mean, isn't there a kind of duty to then scale that up to the population and make that more broadly available, that data? And that's something.
Not the data, the model. There's a difference.
Well, you can do federated learning and you can share the data.
Yeah, fair enough.
Security. So because that's what everyone says. Everyone says we need data, and you can't have a personalized medicine revolution without data. So you kind of have to do it, right?
Yep.
So, there is this sort of dilemma, is there not, about, you develop this thing in one place and then how do you scale it up? Does anyone have a good answer to that question? Because, one of the complaints I hear a lot, and I don't know if you see this, is that, from the outside looking in, it's very hard to sell into the NHS. You can do a pilot, you can do endless pilots, you can do 1 trust, 2 trusts, but scaling up is really hard. I mean, is that still not a problem, would you say?
Well, it is a problem, and across the globe is a problem, and public pay system. Like in Canada, we have public pay system. they have to see a value, and what they see it, the money is allocated yearly basis, and the money is allocated, they have to remove something to bring new technologies inside. So someone has to vote it, someone has to then make the changes there. So there is a delay in adoption. Give you one practical example. In Calgary, in Footer's Hospital, it took them over 10 years to buy a first endoscopic ultrasound after US FDA approval.
Oh my.
So you can imagine that, how delayed sometimes adoptions happen. So it doesn't mean that the technology not working. It just allocation is the key, because it's a large systems, limited resources, and new tech is a play. But what we see as an opportunity, direct to consumer. So direct to consumer, where people are eager. COVID had a paradigm shift. People are very attuned to their healthcare. They want to know what is happening from wearables. They're tracking their symptoms, the periods, body temperature. They're doing so much tracking themselves. So now using that data sets, providing AI agents, such as AI coach for 24 hours, who know them personally, who can provide insights like in hiring a doctor. And that's a market we are focusing on.
Okay, now look, I'm going to let you respond, Parth. And then I want to ask about whether wearable data from patients is useful or whether it should be useful. And then I'm going to open it up to questions. Yeah, I see your hand there. Very good. So if you could just respond quickly, and then we'll move to wearables.
So just back on your question about upscaling within the NHS, having worked in the NHS, there are a lot of red tapes. There are a lot of barriers that we have, despite we have endless pilots, whether it's in one trust or 10 trusts itself. When it actually comes to a a national rollout of any program as such, we always have reservations from different trusts because of the way the different managements work itself. That is the number one challenge. But number two itself is you have different dynamics of your patients. If you look at various trusts, they will be serving different demographics of certain patients itself. In some areas, you have more rural access populations. On some areas, you'll have more urban, metropolitan, more younger populations who would be more willing to adapt to any form of technological innovation that's out there. So by and large, you will have multiple issues that need to be addressed at its pilot stage before you roll out its full-scale implementation. And I think that's where we within the NHS suffer a lot, because we're not thinking about that.
Anke, you're kind of like uber high tech. Do you use patient data at all, like from their wearables? Is it useful yet? Should it be useful?
We don't use just normal wearables that you can buy, at the market, because that's that implies that we can't get the health data into our ecosystem because of the firewall, etc. And we do find that very good health data sets that are being produced in wearables, like, let's say, continuous glucose monitoring, things like that, those are closed shop systems, and we don't get hold of the raw data sets, because that is, of course, its own AI governed industry product, and is being used like as a closed loop as such. And that is in order to, combine this answer to what I've heard just before. And it's like catch-22. I can understand that the industry, somebody has got to pay for innovation and finding and piloting new things and AI algorithms. And then on the other hand, it's really, about interoperability, open interfaces, and global usage, or at least nationwide or within a healthcare system, usage of health data sets with the patient also being involved.
Okay. Fine. We'll take questions. Gentleman down there was very quick off the mark. Anybody else other than that? And a lady over there, please. We'll take both questions. And I see your hand up there. I'll come to you in a bit. Yeah, just down there.
Dr. Limited, Oxford. Thank you very much for this wonderful panel discussion. I just want to ask this is a kind of stratospheric conversations. Our AI needs in the UK are confined to bread and salt kind of thing in Maslow hierarchy. The interoperability of data is, thank you very much for saying this, right? My question is why UK government doesn't fund creation of data sets that answer specific business questions. There is this thing, Komagor, of incompleteness of any library or data set. All the libraries are essentially incomplete in Gödel's sense. And therefore, they have to be, these libraries, data sets, they have to be oriented around business questions. And government should really be the champion of these data sets and the platform, the market maker for data sets. This number question. Number two.
No, one question. Sorry, you had two earlier.
This one is more important.
Okay, but can you make it quick?
Yes. So this one is the and this is to every panelist here. The question: can we build products where data set is a byproduct of the delivery of a service or drug to market? Just like, this captcha that we created in the past. Because data sets are very important.
Take the microphone off him, please. Thank you. Lady over there.
Is it on?
Yes.
Throughout today, I hear we cannot replace doctors. My question is, if AI is democratizing knowledge, is becoming better at diagnosis, it's making decisions or it's supporting the decisions for us, why can't we replace doctors? It's, I think we should be open-minded about how AI is going to change healthcare delivery.
Gosh, I want to answer that.
You want to take a shot?
But I won't. Okay, so we had two very complicated questions from the gentleman over there. Why doesn't the government fund answering business questions? Does anyone want to take that? Does anyone have an answer?
I mean, it's hard to say, right? We're opening a mathematics school funded fully by XTX Markets and in UK. So, that's an interesting.
Oh, Anke wants to come in, but
Yes.
sorry.
I would actually love to answer that because this is exactly what we do in Germany. We founded, it's called the Interop Council, which is a government institution. It was called together by the Ministry of Health, and it's got 7 seats, and those represent 7 groups, like the federal states, the associations, the professional societies, the standardization organizations, scientific institution, patient organizations, industry, very important. And I personally represent the group of the health IT users, and we come together on a nationwide level. And then we've got a national interoperability register, which publishes then fire resources, the profiles, the data objects to make them reusable for everyone. And that is a national institution. It's called the Interop Council in Germany.
Okay, thank you for that. Sorry, you got crashed into. Are you sure you're okay? Okay, so why can't we replace doctors? Who wants to take that one? Come on, Madhu, you know.
Of course, it's like, so the doctors would, and I want Parth to speak. What we found, so the chief medical informatics officer works for us, and he will tell you what he does with these kidney care patients who have multiple comorbidities, including congestive heart failure and diabetes and others. He spends majority of time making sure that they're going to take their 19 medications prescribed by 4 different physicians and show up for dialysis 3 times a week. There is no AI that will make people do that.
I mean, I'm going to throw the question back at you. You could have stayed at home and just Googled all this and asked the AI on the internet. Why?
But Parth is free.
So I think, yeah. And so I have that question because I write about science and technology all the time, and you can get a lot of your answers now by asking AIs. But the reason I hope you will still read what I have to say is that we bring human perspective, we bring meaning to it. And I think probably that's what doctors will do, is that they will bring the human perspective and the meaning to the diagnostics, and it will be a tool that they use, as I use, and we all use in our work, I hope. But, the world would be very different, wouldn't it, if there weren't humans in it and we were all Yeah, sorry.
may-
I feel this really strongly.
Maybe in 100 years' time, if you have a particular problem and you call your GP, they're going to ask you to press maybe 1 for a headache, 2 for diarrhea, 3 for something. That might help
No,
you
it's not
get
gonna
them there, but
All right.
probably just not yet.
No, but it's more, I think it's about trust, isn't it? Like,
Absolutely.
how much do I trust ChatGPT to tell me that? How much do I trust
You
my
don't.
doctor
Yeah.
to be specifically, kind of understand me? And then that's where, for instance, right now, my dream, the next kind of companies I'm backing is digital twins, right? That each one of you has such a great replica of your body, so that my assessment and AI's assessment of what treatment plans has to be so accurate and so good that no doctor can do
Yeah,
that.
Gabrielle, that is where cost will come in. Like, how much will that digital twin cost?
But data as well, right? Not only cost.
But you can't develop digital twin without multi-omics. You need to have multi-omics.
When am I going to have a digital twin, Gabrielle?
So there are already a few companies working on specifically different parts of the body, digital twins. Not the full body mapping is still a bit out there, but we're getting there. I mean, my estimate, it's hard to say, but within a few years, we're getting closer and closer.
Sorry, Natasha,
It'll be the
one more
cost
thing to add on the same question. Sorry, I'll be very brief. Doctors are not just going to say that, okay, what's your problem? This is your diagnosis. You can go home. We have to learn the art of examining patients. We have to learn to try and tie different symptoms down together, understand how the medications work. And most importantly, there is this whole gray area of prescribing medications. Who takes responsibility if there are side effects of a medication? If something is an adverse event, who is going to be held responsible? The ChatGPT, the owner of ChatGPT, the one who has dispensed the medication. There's a very huge gray area there, which again, is absolutely with no regulations there, that still has to be worked upon before we.
But when you look at it from people already go to Dr. Google all the time, right? So
Google's not going to prescribe them anything if it's a paracetamol or ibuprofen.
They said there'd be no Jeffrey Hinton said there were going to be no radiologists, and there are more than ever, right? So what does that tell us, right? And about healthcare demand, right, which is endless. And so I think, I don't think doctors are going to be out of job anytime soon. Gentleman down there and a lady down there, those two. Oh, and the guy with the beard. Sorry, guy with the beard. Yeah. And then where's the other microphone? Okay, that woman is okay. Fine, go on, ask her as well. Sorry.
All right.
I'm getting bullied by the microphone holders. I'm so
sorry. Yeah. So my name's Fiona Loud. I'm from Kidney Care UK. We're a patient support charity, and so I'm delighted to hear you talk about dialysis. So I've a couple of questions. Well, one.
Just one.
Yep. Just one. What is? I'm assuming that when you're speaking about the patients you're working with in this AI example, I'm assuming you're talking about people not in a public health data system, perhaps more in the paid system. And I wonder what your patients think of the way in which you've described that intervention, because it sounds really, really good, but we cannot take patient permission to use our data for granted. And there have been examples in the UK where that didn't happen right with another kidney condition.
Yeah, fair enough.
Okay, can I take the question from the guy with the gentleman with the beard, if you don't mind me finding.
My name's Roger from Business Solutions Company. In the West, governments are going to be increasingly having to put their funding from a diminishing tax income while people go unemployed into defence, environment impact and so forth. It's going to pull funding away from healthcare, most likely. How do the poorer in the West, where they often have to make a payment in order to receive this personalised diagnosis and treatment, going to continue to get that treatment? And are people in the third world countries going to benefit as well?
All right, so can you take that microphone, please, and give it to that gentleman there? I'm going to answer your question. That's a societal question, not one for our panel. And the amount of health money that is spent, that's a question for Wes Streeting and whoever you voted into power. So don't bother with that. Okay, gentleman there.
I think for me, I'm George. I work at London Business School. My question is actually kind of building upon that, I guess, is with the increased kind of healthcare costs in developing new technologies, ideally in other industries, when you develop technologies, they tend to get cheaper. But in across healthcare, it seems that things are getting a lot more expensive.
Yep.
And with the creation of these new technologies, what can, I guess, apart from, I guess, federalizing data, but what can government or regulators or even just the private sector do to kind of bring these healthcare costs down? Ideally, not just for patients, but just for overall innovation.
Okay, fine. And then lady down there. So
that'll be a quick answer on that.
You give the quick answer on the kidney care.
Yeah, that's because yes, it is the insurance system in the US is different, and the second piece is yes, the data regulation in various countries is different, and it continues to cause problems.
Costs.
Yeah. Regarding the cost, I can comment on that. So, from being a cardiologist, so we have seen transition happening in healthcare, right? So we have seen when I'm graduating from cardiology program in Winnipeg, CT angiogram was still coming in, and now CT angiogram is commonly used. Yes, added cost to that, but also help improve risk stratification. We can catch people early on, start medication early as a primary or secondary prevention strategy, and perhaps delay the cost in the hospital system. So yes, new technologies do cost money, and new drugs cost money, but they also help us improve outcomes. We have seen SGLT2 inhibitors. We have seen in many other cardiology medications, they have delayed the onset of heart failure, or at least keep people out of the hospital. And this we save money. So yes, technology should be implemented, should be developed, and because they do help us save money, they help save lives, more importantly.
Okay, and my answer, right, is that is the role of things like the National Institute of Clinical Excellence, ICER, is that basically technology is the biggest driver of increases in healthcare costs other than staffing. And so you have to pick ones you're going to choose, right? And that's kind of like one of the dilemmas, isn't it? Is that, you can have this technology that someone's selling that's going to improve care, but kind of what is probably going to get introduced first is something that's going to cut costs. Okay, last question, so lady there.
Hi, my name's Ifra. I'm a doctor working in the NHS. There's a lot of talk about doctors being against AI and sort of replacing doctors with AI. The issue we're seeing in clinic is that we have patients coming in who are fit and well, who have wearable technology, like ketone monitors, blood sugar monitors, fit and well. So patients coming in, we're worried about things that...
Worried well.
Exactly. So is there a responsibility for the AI innovation side of things to direct people to websites that are reputable or good websites that will tell them, sort of like NHS websites, that will give them good information before they come to clinic with, a long list of symptoms that are benign, but saying I've got cancer?
Right. Does anyone have an answer to that?
Well, AI, think of this way, what the human task is. AI is the same personality. AI has nothing to be scared of it. I'm a cardiologist, I use AI. I use it as an assistant to me. So differential diagnosis. End of the day, I'm very tired. So AI helps us out. Same time, AI agents are coming in play who can direct them, who have been trained to vet these good websites, good resources where a person can go. And AI can also self-generate some of those videos, the content that even doesn't exist even. So AI will be transforming medicine. We don't have no doctors against AI. I'm not, at least not AI. I'm pro-AI. Because why? Because we get tired. We get exhausted in the day. When I'm starting my patient seeing population that's 8 o'clock in the morning, by noon, I'm okay. But afternoon, I'm exhausted. So don't see me at that time as a cardiologist. I may do a bad outcome. But AI never get tired. Right? It's consistent all the time. In fact, AI is more empathetic than the doctors these days. Recent study has been shown. Because why doctors want to get people out in 5 minutes?
Okay,
but
I'm going to give Gabrielle the last
Maybe just add a little bit of data to that, because it's very general. 35% is the amount of already online GPs, right? So that's already better. And now we're seeing more and more training and that release. Investment in agents, right, responding to you. So an agent that looks like you, but is actually obviously ChatGPT behind, and humanizing of that content. Again, going back to trust, that I trust the AI who looks like a doctor and a human. But it's already 35% less in-person appointments as of 2 years ago. So.
Well, look, I've kept you for lunch for long enough. The next session is going to begin at 2:25, and I think you'll all agree they were great, right? So thank you very much. Thank you.